Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and this podcast exists so that we can talk all about your body, your health, your hormones, your fertility. Today, we're going to be talking a lot about the uterus, talking about uterine factor infertility, things you may or may not be thinking about if you are on your journey trying to grow your family. Sometimes the uterus is often overlooked or it is not something that is evaluated until there might be a problem. And I always think it's really important that you know what all could go wrong or what exists out there so you can start to learn more about it. Before we jump in, I just want to say we're going to be answering some of your voicemail questions in this episode, and I'm always so thankful for each one of you that calls and leaves a message. Your questions really helps drive the content of this show, and I know you are sharing a lot of your history and your vulnerable experience and your thoughts and your feelings. And I'm just really thankful for you. If you want to ask your question, you can call 657-229-3672. Again, that is 657-229-3672. And leave a voicemail. You don't have to use your name. Just leave your voicemail. And you can also ask questions on Instagram on Monday at nataliecrawfordmd. Some will be answered there on Instagram. Some will be answered in the weekly newsletter. And some will be answered here at the end of the podcast episodes. So you can leave a voicemail and you can send in your question on Instagram. The weekly newsletter is our way to just keep you learning a little bit about fertility in a really easy way. It has updates, it'll have fertility questions, it'll have some of my favorite products, it'll always have a fertility recipe that I love, and just give you some links to some content you might be interested in or things that some of my friends are doing and what they're up to. It's not spam, very easy. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And if you like listening to the podcast, you probably would also enjoy the YouTube channel. We actually have different videos, little 10-minute bite-sized Q&A type videos. Very easy to search and find information on maybe the topic you really want to hear more about. So don't forget to go over to YouTube, Natalie Crawford MD, find the channel, and then you can start searching for what it is you want to learn more about. Today, we're going to dive in to a little bit about what goes wrong or what can go wrong with your uterus. Now, when we think about the uterus, it's important to understand both its impact from development and how it responds to hormones. So to start, let's just talk through a little bit about the development of the uterus and how it is structured. Your uterus is actually formed from what we call the Mullerian tissue. There's 2 Mullerian buds inside your body when you're an embryo. And then these 2 buds, they elongate. So you get 2 strips of tissue. They fuse together. And then this midline portion that connected them will reabsorb, forming a central canal or a cavity. This tissue, very specifically, it becomes the top 1/3 of the vagina, the cervix, the uterus, the fallopian tubes, meaning the ovaries are a different embryological source. So you can be born without a uterus because the Mullerian ducts do not form and have completely normal ovarian development. Same thing, the bottom 2/3 of the vagina is a different embryological origin. So that can form even if you don't have any Mullerian formation or a uterus. And in that circumstance, that's called a blind vaginal pouch. Now, you can have issues along any sort of this development process. So what could happen? What can go wrong? So you could have failure of both what I just said is called Mullerian agenesis or Meyer-Rokitansky-Kuster-Hauser, which is complete absence of a uterus, birth defect, born without a uterus. You have a blind vaginal pouch. You have ovaries. There's no internal structures. This often presents in puberty because what happens is you actually have ovaries. So you're going to go through signs of puberty, meaning you're going to get breast development. You're going to get sexual hair development. There's no hormonal abnormality, but there is simply no uterus to bleed. So These women usually present with what we call primary amenorrhea, which is if you have not had a period and you're age 16, then you come in for an evaluation, or about 2 years after breast development, if you don't have a period, then an evaluation should be undertaken and they're found to not have any Mullerian tissue. Then you could have failure of just one side. So we'd call that a unicornuate uterus. So you just have one horn, one fallopian tube. You still have both ovaries though. You could have two completely separate sides that just never fuse together. That's called a didelphys. So two totally separate sides. You could have a bicornuate, which is a partial fusion. So they partly fuse the bottom, but the top part of the uterus is separate. You could have a uterine septum, which is where the midline portion just never reabsorbed. And you can actually have a transverse vaginal septum, which is where the Mullerian structure is developed fine, but they didn't connect to that lower 2/3 of the vagina, and you have a band of tissue obstructing menstrual blood flow. And in that circumstance, you typically present similarly with when your period starts, but with cyclic period pain and amenorrhea because you've never had a period because the blood can't get out. These are two extremes. All of the other Mullerian anomalies, so your bicornuate, unicornuate, didelphys, septum, for the most part are asymptomatic. You might have a higher risk of endometriosis because of abnormal blood flow, and you're also at higher risk of having abnormal birth presentations like a breech baby, you need a C-section, and a higher risk of miscarriage. So there's certainly some reproductive abnormalities. I don't ever want to say they're totally asymptomatic, but you're not usually presenting in your younger years with any abnormal bleeding or any sign that is leading us to this diagnosis. So it's commonly found during an infertility evaluation or an evaluation for recurrent pregnancy loss. About 5% of all women are born with a Mullerian anomaly or birth defect of the uterus, and then about 13% of women who have recurrent pregnancy loss will actually find a uterine abnormality on evaluation. Importantly, many Mullerian anomalies may not be seen on transvaginal ultrasound. So what that means, and the way I like to describe this, is if you think about your uterus, I want you to imagine that you have your two hands. So take your two hands and then put them in a prayer position. So your hands are touching. This is what your uterus is like in its arrested state. Now, if you kind of open your hands up or try to act like you're holding a ball with your hands, that's how your uterus is when there's a pregnancy growing inside or there's any liquid or water or anything put into your uterus. So when we think about our triangle-shaped uterus that we see in images all the time, the triangle is a potential space. It doesn't exist in real life. And because those uterine walls are flat against each other, we don't always see inside of it on a vaginal ultrasound. Now, there's some things that might be really obvious, like if you only have a half of a uterus, but there's some things that might not be obvious or might totally be missed and that be fine on vaginal ultrasound. So typically we want to evaluate this with a better diagnostic test of the uterus, and this can include a saline sonogram where water is injected into the uterus while you watch with ultrasound, essentially filling that potential space with liquid so we can see inside of it. If we have an HSG test, which is an X-ray dye test, where liquid goes into the uterus and it's radio opaque and you take X-ray images and you can see the uterus fill up. And then there's also an MRI. So pelvic MRI is a great way to evaluate the uterus. So regular vaginal ultrasound, it might give us the answer, but sometimes it does not. The structure of the uterus is also important when it comes to uterine factor and having a normal uterine response or the role your uterus plays when it comes to infertility. So the uterus has 3 different layers. So the outer layer is called the serosa. The muscular layer, what makes up the bulk of the uterus, is the myometrium. And then the internal layer is the endometrium. And the endometrium actually has 2 layers itself, a functional layer that's going to grow and shed and respond to hormones, and then a basal layer that is underneath it, which has those regenerative cells to help the functional layer grow. So you're bleeding off endometrial cells every month, and the endometrium is what we're aware of. But the uterus does have these different structural layers, and that is important as well. So if you have something that damages the basal layer of the endometrium, that actually can cause scar tissue. So any type of uterine surgery that permanently damages that area can put you at risk to have uterine scar tissue. You can have polyps inside your uterus that can cause local inflammation and impact your ability to implant. You can have fibroids in all the different areas. So fibroids can be outside the uterus or in the muscle of the uterus or inside the uterus. These different locations have different names. So they can be subserosal, they can be intramural or in the myometrium, or they can be submucosal or in the endometrial tissue. And our take on fibroids has changed over time. Fibroids are common. They can cause heavy bleeding, anemia, pain, bulky uterus. There's a lot of reasons for fibroid treatments that have nothing to do with fertility. But if I'm looking through a fertility lens only, we typically are removing fibroids that are inside the uterine cavity, those submucosal ones, or ones that are changing the shape of that cavity. So they are pushing into it or distorting that endometrial layer. Adenomyosis is another uterine factor that can play a role. And adenomyosis is an inflammatory disease. And the easiest way for me to describe it is to imagine that endometrial cells have migrated into the myometrium. Not 100%, but almost all of the cases of adenomyosis come after some type of uterine surgery or a pregnancy. So something has invaded that myometrium. Is that something a surgery, a placenta? Have you had any type of instrumentation into the uterus before? Essentially, think of a pathway where the endometrial cells can get into that myometrium. Because the myometrium is so blood rich, that can cause the endometrial cells to be happy. And then your body starts to attack these endometrial cells, kind of not realizing they're your own. You get this autoimmune version of the reaction, and highly, highly inflammatory. And adeno itself can contribute to infertility as well. So you can have uterine birth defects. You can have structural issues with your uterus. You can also have hormonal issues when it comes to the ability of the lining to grow or to not grow. So when we see uterine factor, we see it from Mullerian anomalies. We see it from polyps, fibroids. We see it from scar tissue inside the uterus, from adenomyosis or other uterine infections or inflammation type disorders. So there's a variety of different things which can come in and impact how our uterus is functioning, in addition to just having an abnormal response to the hormones estrogen and progesterone, which is part of what that lining, that functional layer of the endometrium, that's its goal. It has to grow, it has to shed. It sounds really easy to say or to think that, well, I have regular periods and I had that ultrasound one time, so my uterus is fine. Importantly, there's a lot of different ways to evaluate the uterus, like we mentioned earlier: vaginal ultrasound, saline sonogram, HSG, MRI, hysteroscopy, putting a camera inside the uterus, laparoscopy, putting a camera in the abdomen and looking that way. So there's many different evaluation tools, and we have to know what is going on in order to evaluate. What we're going to review, you're going to hear some patients' questions, and these are all in circumstances of infertility. But if you have some abnormalities happening with your period, your cycle, heavy, you're bleeding through your clothes, something seems off, you always bleed around a tampon, these things could be warning signs that there's something bigger, and we might want to evaluate your uterus before you even start trying to get pregnant or before you get a formal infertility diagnosis of trying to conceive for a year without being able to. So remember that uterus is an important piece of the puzzle, and let's answer some of your uterine anatomy questions when it comes to infertility. Again, if you have questions, you can call and you can leave your questions on the As a Woman voicemail line. Those are the questions you're hearing right now. The voicemail number is 657-229-3672.
Hi, Dr. Crawford. Just want to say thank you for all that you've done. I've learned so much from your podcast, through your Instagram, through your blog, newsletter, via email. I just want to say that I appreciate everything that you're doing for this community. I have a quick question about septums. I'm going through a series of fertility testing, had an ultrasound. They were suspect of a small septum, and then I did my saline sonogram yesterday, and they did confirm they found a small septum measuring 1/2 centimeter. The doctor just called me saying she's recommending removal. I'm just a little skeptical given that it is so small. I've never been pregnant. They said that could be the reason why. But a lot of what I've read is it's more of an issue with miscarriages, which I'm happy to get removed for that. I'm just not convinced that's the reason of why we're not conceiving. So I would love to get your advice on this. Have to make a decision to get surgery or not in the next few weeks. So hopefully you can answer it. Have a great day. Thank you.
A uterine septum is failure of that last stage of the uterine development, which is reabsorption of the midline connecting tissue. This is the most common Mullerian abnormality. It is typically totally asymptomatic, but it can present with pregnancy loss. I personally have also seen patients present with infertility, which can make sense if you think about the mechanism of action. If we imagine your uterus, you've got this tissue that is avascular, meaning doesn't have blood flow, hanging down into the uterine cavity. That avascular tissue makes it hard for a pregnancy to come and implant. And depending on the size of it, the thickness, how much of the cavity is obstructing, it's going to have varying levels on if a pregnancy can try to implant on it and then miscarry, or if it potentially will just prevent pregnancy altogether. Some studies show up to an 80% chance of pregnancy loss if you have a uterine septum in place. There has been a lot of debate on this in the field, meaning there are some older school physicians who strongly believe that you should not take a septum out until somebody has proven, in quotes, that they have infertility or that they have had recurrent pregnancy loss. There are other people who err on the side that take it out sooner so you don't have a problem. I fall more into that camp, and the true right answer is probably somewhere in between for any individual patient. To me, I don't want to put somebody through infertility or pregnancy loss if it could have been prevented. If we find out you have a septum during some piece of an evaluation, I'm always going to recommend that we remove it. For context, if we're doing IVF and we've got an embryo, we're 1,000% removing it before we get to that IVF standpoint. The good news is the smaller the septum, the easier the surgery is. The recovery is typically faster. You have a lower risk of scar tissue or other formation. But I would do it for peace of mind in order to get to the next step. But understand that in your position, people could argue both ends of that. So there's no right or wrong choice, but I want you to kind of understand that it can be contributing to difficulty conceiving. Thank you so much for calling and for sharing and leaving your question. And now we're going to move on to our next one.
Hi, Dr. Crawford. I actually just got done listening to your Q&A episode on the uterus and uterine abnormalities, and I did have one additional question that hopefully you can help me with. I am 37 years old and currently on my 6th miscarriage. They were all very, very early, 5 to 8 weeks. I now have had 2 ultrasound techs mention to me that my uterus is a heart shape. I have had an HSG as well as an SIS in the past and was told that everything looks normal. There's no concerns and it's all good. But then the ultrasound techs keep mentioning the heart-shaped uterus. I know that at age 37, likely the genetic abnormalities of my eggs might play a role in my recurrent miscarriages. But I also wanted to ask if potentially having a heart-shaped uterus could play a role, and if so, a surgical correction would make a significant difference. I would, of course, consider IVF, but I don't want to move to IVF if my risk factors is recurrent miscarriages and I'm just going to have issues with implantation or having the embryo continue to grow past that 6-week window that we seek to not make it past. Yeah, so if you have any insight on what you would recommend for potential surgery or anything else, I would greatly appreciate it. And thank you so much for everything that you do.
One thing that is often confused or can't be distinguished on an HSG test is the difference in a uterine septum and a bicornuate uterus. A bicornuate uterus, again, is where you had partial fusion, so the entire top of the uterus did not come together. And then the septum is where you had partial reabsorption. The reason why is both of these have a heart-shaped uterus on the inside of the uterus, but the outside of the uterus would look different. So in a bicornuate, the top pieces didn't fuse, so you have a heart-shaped uterus from the outside as well. And on a uterine septum, the top of the uterus is more flush. And this is an important distinction. A bicornuate uterus does carry a higher rate of miscarriage. Studies have quoted between 25 to 50%, where if we think about general population, it's closer to about 20 to 25%. That's nowhere as high as 80% like we see with the uterine septum. And certainly having 6 pregnancy losses is highly concerning that there could be something more going on than just bad genetics. Because at 37, you should still have a decent amount of your eggs genetically normal. Every single egg shouldn't be bad. So I'm sure the complete recurrent pregnancy loss workup has been done, looking at karyotypes and clotting disorders and endocrine factors and things like that. But because of this reproductive history with this heart-shaped uterus finding, I might think about asking to see, could we get a pelvic MRI and see if that could distinguish, making sure this isn't a septum. Typically, a saline ultrasound done in the right hands is going to give the answer, but it's not always clear. An ultrasound is influenced by so many different factors: gas, your body habitus, your level of if you're on your period or if you are on birth control. And so if we're really trying to get to the bottom of the answer, I might say, hey, ask your doctor about an MRI and see if that might give you maybe more confidence if it is just a heart-shaped uterus. You are correct in what you're hearing is that if it is a bicornuate uterus, we do not recommend surgery for this. Surgery for this was historically done. You would go take out a huge chunk of the uterus and try to sew the two tops together, and you ended up with more harm than good, meaning the miscarriage rate's higher, but it's usually not every pregnancy. You do have a higher risk of breech presentation and C-section, but typically you can get pregnant and carry a pregnancy. So if it is bicornuate, I would not recommend surgery, but if it is a septum, then I would recommend removal. Wishing you all the best. All right, we're going to move on to our next question. And remember, if you want to call and leave a voicemail, 657-229-3672.
Hi, Dr. Crawford. First, I just want to thank you for all that you do. This content that you put out has been extremely helpful in my trying to conceive journey. My husband and I have been trying to conceive for just over a year now. I'm 33 years old. My question for you is about uterine polyps. In June 2024, I had 2 polyps removed via DNC. They were both measuring at 1 centimeter in size. Those were found via a saline sonogram shortly before that. Continued to try to conceive naturally, which did not produce any positive pregnancy. So I began seeing a fertility specialist in November of 2024. I'm currently on my 2nd medicated cycle with them. And in my sonograms, they began to notice like a density or a shadow in those images. So I recently had another saline sonogram and they found 2 more polyps, both much smaller, about 4 millimeters in size, with some additional surrounding tissue. And their recommendation is that I have another DNC to remove them before we potentially move on to IUI cycles. One, I'm just a little concerned that I'm having 2 DNC procedures so close together in time. I'm just concerned about any scar tissue or damage to the uterus that might continue this infertility that I'm experiencing. So should I be concerned about that? And the second part is it does sound like my OB may have access to a tool that can be used to target these polyps versus just doing a blind DNC procedure. She says it's a little bit more complicated to get that scheduled, but just wanted your opinion on if it would be worth advocating for that and moving forward with that versus a regular DNC. Also, in my first DNC procedure, I was not prescribed antibiotics. So in listening to your content, I am a little concerned about that as well too. So just wondering if I should advocate for that in my next procedure. Thank you so much.
Many good questions, and I'm so sorry you're going through this. Number 1, polyps, they come back, and that can be one of the most frustrating things about them. They do cause inflammation inside the uterus, and I agree with your care team. When I see a polyp and somebody's trying to get pregnant, I want it removed. Now, one thing that I think is really important here, a DNC procedure is often a more blind procedure. There's different ways you can do it. There's suction device, there's sharp curetting, But essentially, you're putting instruments into the uterus and taking out the tissue, sometimes done under ultrasound guidance, sometimes just done by feel. Now, to be honest, I've operated on a ton of uteruses, and you can feel the inside of them really well. And I don't want you to think that that sounds crazy, even though I know that that sounds crazy. However, it is a blind sampling, and so it might leave a polyp behind. It may not be perfect. I prefer a hysteroscopy, which is when you're putting a camera inside the uterus, for a directed polypectomy. This can be done with scissors and polyp graspers. That is one technique. That's what I do. But I believe the device your doctor is talking about is this tiny little morcellating device that works the same. So it's still with a hysteroscopy where she'll put the device right to where the polyp is and then take it off with that device. And so either way, no matter how it's done, I would want to advocate for not a blind DNC at this point, but for a targeted removal of the polyp, whether that is with the device or with instruments. Whatever your doctor feels most comfortable with is always what you're going to want to advocate for. As for the antibiotics, it is not a hard, fast rule that every hysteroscopy needs them. In fact, most of the time, patients are going to be just fine, and it's fine to not proceed with them. I like giving antibiotics with surgery just because I deal with patient population having infertility specifically, and I always want to make sure if I'm putting an instrument in the uterus that I'm not just having a very low risk, that I have no risk of getting an infection inside the uterus. It's not wrong to not prescribe antibiotics. It's probably the more standard of care. You certainly can ask your doctor about it and see what they think. And sometimes people do it more if they're doing more invasive technology, like putting the water in the uterus versus just the DNC, because that water might move through the fallopian tubes. And that's a circumstance where antibiotics are indicated if you're doing that. So might depend on actually what procedure you end up having. I hope you have the polyp removed and get pregnant, and sending you all the good vibes. We're going to answer one last question for this episode. Remember all the places that you can follow and ask your questions in the future.
Hi, Dr. Crawford. My name is Robin. I first want to start by saying thank you for your podcast. It has been a great resource for my husband and me during our IVF journey. We started IVF in February 2024 after a 10-week miscarriage. I'm a carrier of a Robertsonian translocation, so we anticipated IVF might be necessary. I had complications from the miscarriage that led to 2 DNCs and a hysteroscopy, which we completed both. We completed our egg retrieval with 33 eggs, resulting in 3 euploid embryos, but my lining didn't respond. My doctor completed a second hysteroscopy where I was diagnosed with severe Asherman's, about 80% scarring, which my doctor was able to successfully treat. However, during my first medicated frozen embryo transfer cycle, it was canceled due to poor lining response. I went from a 5.4 to a 6.4, then down to 4.7. I'm feeling pretty discouraged, so was just wondering if there is hope and what you would recommend as next steps. Thank you. Bye.
I'm so sorry for everything you've gone through. And as somebody who's gone through loss, I know how hard it is. I think one thing we don't think about very often as women going through this process before it happens to us is how long one miscarriage can drag out and how impactful it can be to your future fertility. Meaning this one loss you had, it got pretty far along, the multiple surgeries, now the scar tissue, more surgery. It's putting you into this really not fun cycle, and I'm sending a big, big hug. Now, Asherman's is in fact scar tissue inside the uterus. This is typically caused from uterine surgery or damage where that basal layer of the endometrium is damaged. Therefore, it cannot regenerate and grow that functional layer. Now, when you take out Asherman's, it might come back. It can be hard to overcome completely. Vast majority of patients are going to be left with a residual thin lining. Risk factors for this include any type of uterine surgery, having fibroids out, having a septum removed, but more specifically is anytime there's been a placenta inside that body. So miscarriage, postpartum, if you needed procedures for those, we're upping the odds. And the longer a miscarriage took to resolve, we're increasing the odds that we're going to be left with some residual scarring. No period or very light periods afterward can help get you this diagnosis faster. When it comes to on the back end, you're doing everything right, meaning I recommend IVF for my Asherman's patients so that we can be doing genetic testing of embryos so we can put a genetically normal embryo into the uterus. Same logic applies. We don't have the bandwidth now of our uterus to have many more losses, and we need to prevent that in every way possible. So even if you hadn't had the Robertsonian translocation getting you into this place, doing IVF would be the next step, so you're already doing that. The good news is that aligning a 6.4 is, I think, awesome for an Asherman's patient. I often have very different thresholds than I would have for, quote unquote, a regular patient. Meaning, if somebody's lining might want to get to 7 or 8, if they've never had Asherman's, that might be very unrealistic in the setting of you've had uterine scar, we've gotten the lining to regenerate. So I think having an honest discussion with your care team about what's your goal lining and what went wrong. Having the lining go from 6.4, dropping back down to 4. Why? Did you start to ovulate early? Did you start to make progesterone? That's a very unusual response. So I'm curious about that medicated cycle. Remember that there's different types of cycles. And so often in this circumstance, I actually really love what I call a modified natural cycle for the embryo transfer. And this is where you're going to take gonadotropins like you took for the IVF cycle, FSH shots. And this is going to get your eggs to grow more than one egg at a time. But because of that, you're going to have more estrogen made, saturating the lining. And many people, especially if you've had Asherman's in the past, their uterus responds better to their endogenous or natural estrogen as compared to estrogen pills or patches or shots. So I would want to make sure you have a WTF visit with your doctor, figure out what maybe went wrong, why that lining dropped. If they thought you ovulated or something happened, maybe that could be prevented with Lupron or another medication if there's some other indication for a medicated cycle. Other tricks I like is vaginal estrogen from the beginning. So oral and vaginal estrogen from the very beginning. The vagina is mucosal surface. It's so absorptive. So putting an estrogen pill there, it doesn't have to get metabolized to the liver before it takes a chance to get that lining growing. And I see some women, they just have fast natural metabolism, and that vaginal estrogen makes a big difference. So my thoughts include, if you're doing a controlled or medicated cycle, why do they think it shrunk? Should you try to prevent ovulation with Lupron? Do you need oral and vaginal estrogen or changing up the mechanism of action? But on a bigger level, this is a circumstance where I would love to try a modified natural cycle with gonadotropin injections to see if I can really max out what that lining would be. And no matter what protocol you're choosing, sit back and ask your doctor what your goal lining is going to be. And it shouldn't be something like 8 millimeters or 7. Usually for Asherman's history, we're pretty happy if we can get to 6. It's going to be a personalized goal. If it's organized and pretty, that can trump any size. And I've had patients with very thin linings get pregnant. So I don't want you to feel like everything is lost. It's not. All right, friends, thank you guys for calling and leaving questions. This just helps everybody else learn a little bit more about their body. I'm so appreciative to all the kind words, everything you're asking. Other people are asking as well. Thanks for your support of the podcast. Don't forget the YouTube channel at Natalie Crawford MD. Don't forget you can ask your fertility questions by calling and leaving a voicemail, 657-229-3672. And you can go to Instagram and leave your questions on Monday at Natalie Crawford MD. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at Natalie Crawford MD, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.